Hi everybody, welcome to our first installment of what we're calling ECG Insights. And I am here with Dr. Jaffe. My name is Alex, and we're just going to be basically going through 5 ECGs where we're going to be diving into some of the ins and outs of how to analyze a 12-lead ECG and go through some clinical scenarios and kind of just have a general conversation about ECGs. So pretty excited to have you, Dr. Jaffe, and appreciate you being here.
My pleasure.
So before we get into any type of learning objectives, I just want to provide a little bit of a background about ourselves. So once again, my name is Alex. I have experience as a cardiac RN in the cardiac ICU, also doing some float nursing in general care PCU areas. I've also helped support ECG education for the last 10 years. And then as far as Dr. Jaffe, a lot of people know you as an overreader of 12-lead ECGs. A lot of our staff consider you an ECG expert, needless to say. But you do a lot outside of just overreading ECGs and providing you just a little bit of background about yourself here. So you joined Mayo Clinic back in 1999. That's just a short little minute ago. But otherwise, you've been overreading for ECGs for about how long?
Well, my whole career, over 50 years.
Over 50 years, okay. So a little bit of experience over reading ECGs. But as far as other things that you do to help support patient care across Mayo Clinic and make a significant difference to patients, you are a consultant in the Department of Cardiovascular Medicine as well as the Department of Laboratory Medicine and Pathology, where you're also an academic professor, and you have a chair in the Wayne Catherine correct me if I'm wrong, how do you say that?
Wayne and Catherine Purcell.
Purcell, Professor of Cardiovascular Disease and Research. And then you've also, you have cutting-edge cardiovascular research, which explores surrounding many common cardiac biomarkers, which we'll hopefully get into here in a little bit. But then something that was newer for me to learn about was that you were actually one of the first people responsible for the validation of studies for cardiac troponin assays. And you have about 5 books and then over 1,000 peer-reviewed articles, kind of specifically on those different topics. So, really looking forward to diving into some ECGs with you.
It'd be my pleasure.
All right. So the learning objectives for these presentations, we're going to dive into our ECGs, which could include anything from 12-lead ECGs to inpatient telemetry, Holter monitoring, MCT and events. For this specific presentation, we're going to focus on 12-lead ECGs, and where we're going to dive through different key features, including heart rates, rhythms, intervals, waveforms, and then we're going to just apply these basic ECG interpretation skills to recognize common arrhythmias, and then we're going to get into other core concepts as it applies to different allied health roles, varying anywhere from the technical staff that helps support HRPML, but then all other staff really across the practice. One of the first things that I wanted to dive into with you, Dr. Jaffe, is just to the general approach to how do you approach a 12-lead ECG? How do you analyze your measurements? When you look at a 12-lead ECG, for a lot of people, it can be very overwhelming to start. Just to get us going, would you mind kind of just walking us through how you would approach a 12-lead ECG?
Yeah, I think you have to do it systematically. The first thing you need to do is look for the P waves and look for the P wave axes. The P wave should be upright in 1, usually upright in F, and if they're not, as you see it comes from top to bottom, then most likely it's not coming from the SA node, and it may not be sinus rhythm. You then need to look at each interval conscientiously. There's a tendency to sort of sight read and say, it looks okay, and believe the computer. But I change the measurements probably 5 to 10 times a day because I think the computer has made a miscalculation.
Yeah. Usually the computer's pretty good, but it's always good to do that manual verification.
Well, sometimes it gets the QRS complex wider than I think it is.
Absolutely.
Sometimes it gets the QT interval wrong, depending upon how it is. So I look there and then look at the P waves and the P wave relationship to the QRS.
Absolutely.
What the PR interval is. Then I look at the QRS. Is it wide or is it not?
Right.
And then you look for the ST and T waves, and we'll talk about normal conduction in just a minute in terms of what those things ought to look like. You then will look at the ST segments and the J point, which is the point at which the ST segment takes off, at least in theory, ought to be at the baseline. It shouldn't be elevated, it shouldn't be suppressed.
Absolutely.
And then you look at the T waves, and as we'll talk about in a minute, the mean T wave vector and the mean QRS vector should be what we call concordant. That is to say, generally in the same direction, and if they're not, that's a problem. And that's important from the point of view of some of the people who are watching and some of the technicians as well, because it means if axis moves leftward and the QRS axis is leftward, such that there is a negative deflection in, say, F, the T wave may be inverted in F. And that's what you should expect. That's not necessarily an abnormality.
Right.
And if you take a look, what generally is thought to occur is that you start at the SA node, and there are intranodal tracks. Their names are Winky, Bachman, and Thoreau, but they're not. It's not important. Bachman bundle goes over to the left atrium, and you then go to the AV node here, where there's a delay, and then bundles. The right bundle usually stays a discrete chord to the apex. The left bundle arborizes into a variety of segments, an anterior segment, which really is superior, and what we call a posterior segment, which really is inferior. Some people think there's a central septal fascicle, but these are sort of accumulations of fibers, so you can see whatever you want depending upon how you look at it. But because this arborizes first, conduction starts here, left to right. And that's the reason why we see left to right conduction as the initial part of the QRS. Because the left ventricle is larger in terms of mass by and large, you usually don't see much from the right ventricle until the left ventricle is done and over.
Yep.
So you then see right ventricular outflow, and the last part of the right ventricle to depolarize is the outflow tracts. And so having a little bit of an R wave in V1, for example, an anterior deflection that's anterior and superior, is perfectly normal if the QRS is of normal duration.
Right.
All right, so you then can look at all of these. Now, one of the things that I'll mention, just since we have this putatively normal slide up, is it's fairly common to see a little bit of ST elevation like this, and often if it has a little bit of a superior deflection first, this is what was described initially as early repolarization by a fellow named Al Parisi, who was looking at thousands of ECGs during the Korean War, all in men, by the way. And usually early repolarization is in the lateral leads, it can be in the inferior leads, sometimes it can be in both. But you shouldn't consider early repolarization elevations and J-point elevations in the anteroseptal leads conventionally.
Right.
So there's a tendency for all of us to be concerned about ST elevation because at times it can be indicative of an acute myocardial infarction, but this sort of coving helps you know that this is not true ST elevation, and one needs to be careful to make that distinction.
Right. It's more of a concaved ST.
Yes.
ST.
And I usually will call early repolarization in the inferior and lateral leads. Generally, I avoid that designation in the anteroseptal leads.
Yeah, I think whenever I've analyzed an ECG for early repol, you see that J-point notching. That's kind of like how I've described it in the past, that slight J-point elevation and that swoops all the way back down. There might be some ST elevation involved, but that J-point comes up, creates almost what I would consider almost like a smiley face. and you get that J-point elevation, that concaved ST elevation as well, but early repole is...
Was usually, it has always been considered a benign abnormality, potentially.
Absolutely.
But there was a paper some years ago that suggested an association with sudden cardiac death that has made it more controversial. But that has included, if you look at that analysis, more diffuse patterns of ST elevation. So one needs to be careful. I still think, by and large, early repolarization is benign. But I point that out for anybody who reads the literature. There is a syndrome of sudden cardiac death thought to be associated with early repolarization. And my guess is, with the AI ECG, we'll be unmasking some of the real, truly underlying abnormalities that are over and above that of early repolarization.
Absolutely. So I know that you kind of talked about the usual deflection here in lead 1 and AVF. So when you're talking about what's considered normal on an ECG, when you're looking at lead 1, it's normal to have positive P wave, positive T wave, usually positive QRS complex, but the QRS complex isn't necessarily maybe as important to be positive compared to your P wave and T wave when you're talking about like looking at lead reversals.
From the point of view before we go to lead reversals, P wave should be upright if it's got its normal conduction.
Yep.
If the axis moves rightward, one can have an inverted T wave in keeping with the concordance between QRS and T wave axes.
Absolutely.
So the T wave is much more influenced by the mean QRS vector than is the P wave, which has some degree of independence.
Absolutely. But otherwise, in terms of like, as we look to like our measurements, you know, usually heart rate is 60 to 100, but it's okay to have a heart rate below that 60 beats per minute. Mainly looking for your P waves as you go across your ECG, looking at lead 2, V1 as well, which V1 it's normal to kind of have that slightly biphasic P wave.
Yeah, and in the hospital we almost always use a V1 or a V2 lead.
Absolutely.
Because it tends to give you better view of atrial activity.
Absolutely. So then when it comes to your QRS complex, a lot of the times with the text, anything less than 110 is you're looking for to be considered normal. 112 or 120 is usually kind of a, you know, determining whether you're talking about an IVCD or a bundle branch block. But as you get into that 110 range, 110 is usually where we're kind of looking for those significant abnormalities when you're looking for IVCDs, getting into the incomplete bundles and whatnot. And then QTC, depending upon...
Let me make one comment just about QRS. There are some people who would believe, and we don't make this reading here, but people should be aware of the concept that right bundles may not quite be 120 the same way left bundles are. And some people are willing to call right bundle branch blocks at 115, 112, etc., because of the lower density of muscle that's in the RV and lower size. So some people would say that you should start calling an IVCD probably at 95 or 100 milliseconds, and particularly if it has a right bundle configuration.
Okay. Yeah, I know we got another slide coming up here, so we can dive into that a little bit more. As far as QTC goes, I know when we're talking about a normal QRS duration, depending upon the sex of the patient, 470 is usually kind of a good number that kind of sticks out a little bit as we're assessing QTC, whether it's prolonged or not. And then as we're looking at the R-axis, usually we're looking for that number to be negative 30 to positive 90.
Well, let's go back to the QT just for a moment.
Absolutely.
Sometimes it can be hard to measure a true QT interval.
Absolutely.
Either because the T wave is flat or the baseline is flat, and you know, ideally you'd like to measure it where you can really see the start of the QRS and the termination of the T wave. You don't always have that advantage.
Right.
So you have to do the best you can, and sometimes that's when the computer can be problematic. Yeah. It can overcall or undercall those sorts of determinations. Now, the other thing is that the raw determination itself is not what's diagnostically important.
Okay.
In order for the heart to function properly electrically, you can't have depolarization and repolarization occurring on top of each other. So as the heart rate increases, depolarization stays pretty much the same, but repolarization speeds up,
Right.
so that the QT interval needs to shorten so that we don't end up having the depolarization and repolarization one on top of the other.
Right.
So you need to correct the QT interval for the RR interval.
Right.
There are 19 different formulas to do that. The one that I like to use is called Bizet's formula,
Yep.
which is the QT interval over the square root of the RR interval in milliseconds.
Absolutely. I think that's what we primarily use on all of our ECGs.
Yes.
Is there, when you're analyzing the accuracy of a QTC, are there more accurate leads when assessing an ECG? Like, do you have specific leads that are recommended when analyzing a QTC?
In the ideal world, you're said to look at the V leads, but sometimes the V leads don't give you the best measurement.
Okay.
So I usually take where I can get the best measurement,
Absolutely.
recognizing that the V leads are what you're supposed to focus on, and often that's true that it does give you the best measurement.
Right. Because, yeah, it's nice if you have a 12 lead, but in a lot of our systems that we like for like Holters, MCT and events, we don't have V leads. So if you get you can get an accurate QTC measurement in your lib leads or your augmented leads as well.
Sure.
Absolutely.
And in terms of the axis, one of the things that the computer does for you, which gives you an immediate check, is it does give you the R wave axis and the T wave axis.
Absolutely.
And they should be concordant, at least in the frontal plane, by 60 degrees. If they're not, there's a T wave abnormality.
Right.
But if they are, even if you have a T wave abnormality that looks different than you're used to,
Yeah.
that may be normal still.
Okay. But in terms of axis, in the general sense of how this number is ultimately created, it's pretty much developed all in your limb leads.
It's
in your
all in
augmented
the limb
leads.
leads and the augmented lead.
Yeah,
That's right.
and so like in a normal ECG, you'll usually see positive deflections in leads 1, 2, and usually in all of your leads except for AVR, right? Usually if your axis is normal.
If your axis is normal.
Right.
As your axis moves leftward, obviously you get more inferior involvement, and when you get an anterior fascicular block and things of that sort, that's superior displacement, and you get bigger voltage in L, and you get inverted in the QRS being down sloping in both both 3 and F often.
Right. Anything else to expand?
No, I
off
think
of
that's
this
good.
ECG? Okay, thank you. So now we're just going to be getting into, we have a total of 5 kind of miscellaneous ECGs where we're just going to be talking through various concepts. And kind of the first one is this ECG, which I feel like this ECG is fairly common. You can kind of see the abnormality kind of right away, and we alluded to it on the previous slide. When you analyze this ECG, how would you approach
Well,
it?
the first thing is you want to say that it's normal sinus rhythm. The PR interval looks to be the upper limit of normal.
So we have a normal PRI at 192,
All right.
and we're identifying P waves here in lead 2,
Yep.
2, 3 AVF,
Okay. The QRS is wide.
144.
Okay. I actually agree with the computer in this instance. And it has a configuration we'll talk about in just a moment.
Yep.
And the QT interval, and then the R and T waves. Now, the QRS complex is wide, and where is the delay, if you look? Well, the delay is terminal, it's at the end, rightward, anterior, and superior. If you look at the leads, it's terminal, it's rightward, superior, anterior. Okay?
Okay.
Now, we talked earlier that you don't see much electrical activity from the right side of the heart or from the right bundle distribution
Right.
until the left bundle is finished. So here you have a terminal rightward, superior anterior. That's where the right ventricle is. So this is a classic right bundle branch block from that perspective.
Right.
And it's important to think of it that way rather than looking for some of the clues which often are considered the rabbit ears, which are probably most ideally seen in V2 and V3 here.
Yeah, you
But-
have that RSR prime configuration and the bunny ears that
Yeah.
you're talking about here.
Yeah, but those can be missing. And you can still have a right bundle branch block. They can be masked by things like anterior fascicular block. And if so, you need to make sure if it's a terminal rightward superior anterior QRS delay, you still have a right bundle branch block.
Absolutely.
And we talked about when you have normal conduction, you have concordance between your mean T wave vectors
Yep.
and your mean QRS vectors. But when you have a conduction defect, then those become discordant. And the STT waves will be opposite to the QRS in the leads that look at the conduction defect, which would be the anterior leads like V1, V2, and V3. And theoretically, at least, could be in RN1.
Okay. So when you're talking
Usually.
about discordance, your QRS complex is going this direction.
Right.
And your T wave is going
Correct.
the other direction.
Correct.
Absolutely.
Now, we would read this then as right bundle branch block with secondary STT wave changes. Now, sometimes the secondary STT wave changes aren't there.
Right.
And there are multiple potential etiologies for that. First of all, the precordial plane looks left to right and anterior to posterior, but there's an inferior to superior aspect. So you can have tall, thin people in whom the leads are too high or too low, and you have vectors going away from those leads.
Okay.
So if indeed you don't see what you suspect to be the T waves in the opposite direction, one possibility could be that it's what we call pseudonormalization. That is to say, it's ischemia
Right.
of some sort. But it also could be due to a variety of lead placement situations. So what we do here, the way most of us read, is we read this as right bundle with secondary STT wave changes. If you didn't have those secondary STT wave changes, we just call it right bundle branch block and not comment. Now, the STT wave changes, however, should not go very much beyond V1, V2, and V3.
Right.
And so if you see them elsewhere, then it's probably not solely a reflection of the right bundle itself.
Right. So you can see your secondary STs and Ts here in your V1
Right.
through V3, but you can look other places to analyze the STs.
Well, you have to, because in point of fact, if you have STT wave changes in leads where they shouldn't be
Yeah.
for a right bundle branch block, that's in contradistinction, by the way, to a left bundle, because a left bundle is a very early delay, and so by and large, almost all of the mean STT wave vectors are opposite the mean QRS. But in right bundle, that's not the case. So you still can look and should. Now, if the STT waves are diffusely abnormal all over, that's a non-specific STT wave abnormality or non-specific T wave abnormality.
Right.
But if they're focal, then they are more apt to be due to ischemia. Could be lateral, could be inferior, but you can't have it both ways, which is to say if it's diffuse, it's diffuse. If it's focal, it's focal.
Yeah. One of the things so obviously this is as you described, this is your pretty typical right bundle.
Yep.
Secondary STs and Ts. As we start talking about adding fascicular blocks, so that's very common when you see your right bundle branch block, but then you also see your R wave axis either going rightward or leftward. So you see maybe some axis changes in your limb leads and your augmented leads. When it comes to going from a right bundle to a bifascicular block. Can you kind of explain some of the physiology maybe behind that a little bit? Because you have more going on than just the one branch
Sure.
being blocked, right?
Let's just take the anterior fascicle to start with.
Yeah.
The anterior fascicle, as I told you originally, is really more superior than anything else.
So that as you're going this
Yeah.
way, that's more.
So you tend to get summated values in the area of slowed conduction. So you tend to see leftward axis.
Yep.
You maintain initial normal depolarization at the beginning, then leftward axis, increased voltage in AVL, and then the loop is counterclockwise, so it goes up, and you then see that the R in R is after the R in L.
Okay.
All right?
All right.
Now, the reality is that if you start tall and thin and your axis when you started was 90, then when you develop an anterior fascicular block, you may not reach a magic number of minus 45, which is what we use
Right.
arbitrarily because we can't see the patient and add the clinical findings to
So
it.
you'd see that minus 45 right up here.
Well,
If you were-
if it were more minus 45, but
Yeah.
for example, what I'm basically saying is you can have an anterior fascicular block and not reach minus 45, but you can't apply that to ECG reading because we don't have the clinical characteristics that allow us to make that distinction.
Right.
So we use an arbitrary number of minus 45. And so there's some people who we call left axis deviation, and they're at minus 44, and they don't have an anterior fascicular block.
Right.
But if they have the constituents that we talked about, normal initial forces,
Yep.
increased voltage in L, and the R and R being after the R and L, they probably clinically have an anterior fascicular block. If you were seeing that patient clinically, as we often are,
Right.
then we might make that call.
Right.
But we don't make that call when we're reading the ECG and we don't have that information.
Right.
And the same concept, at least, occurs with the posterior fascicular block. All right? A short, squat person is not apt to develop an axis that gets rightward enough to meet arbitrary criteria for a posterior fascicular block.
Right.
But if the constituents are, again, typical of a posterior fascicular block, that may still be present. We have to use the axis because we don't have any other information to use.
Absolutely. So, kind of just bringing it back to just the basic right bundle for a second. In terms of if this was a patient where brand new right bundle branch block, never had it before, from a clinical context in terms of taking care of the patient, and it's a new right bundle, are there any other, what would you do as a provider to further assess the patient?
It depends upon the clinical context.
Right.
The most common cause of conduction abnormalities, really as we age, is sclerodegenerative disease of the conducting system.
Right.
Like all our systems, as we get older, they get relatively senescent. And that's why our hair changes color if it stays where it's supposed to, and why we see a variety of other changes. So, and sclerodegenerative disease of the conducting system is fairly benign. On the other hand, if you see this with an acute myocardial infarction or after an acute myocardial infarction, it usually bespeaks the fact that this is an anterior or often an interseptal myocardial infarction.
Right.
Those, on a statistical basis, tend to be larger in size, so they reflect damage to the conducting system itself. And we used to, we don't anymore, in days gone by, before we had things like cutaneous pacing, put pacemakers prophylactically in people who had right bundle left axis,
Right.
because the progression to complete heart block with a big anterior infarction was common. We don't do that anymore for two reasons. Number one is we intervene on those patients earlier and reduce the size of their heart attack.
Right.
But in addition, we now can can cutaneously pace people if indeed they get into problems, and we don't therefore need to put in temporary wires to protect them.
Absolutely. So when it comes to like if they have a heart attack in their LAD, an occlusion in their LAD, that area could potentially affect your bundle branch system and ultimately result in a brand new bundle branch block.
Yeah, and it tends to get the fascicles and the right bundle to a greater extent. Now, in fairness, the proximal part of the right bundle is also fed by the right coronary artery. So you can have an occasional patient, in particular who has an RV infarction,
Right.
who might get a right bundle branch block or increased R waves in V1 at least, just due to that, the fact that the right bundle is fed by the right coronary artery as well. And that might, so you can't always say it's an anterior infarct.
Yeah, so it is just very much dependent upon where exactly that occlusion and that patient's coronary anatomy and everybody's electrical system is fed a little bit differently.
Right.
Okay. All right, next ECG. So this ECG is obviously a little bit faster. It's a little bit different scenario. As you're analyzing this particular ECG, how would you recommend somebody walking through this?
Well, when you start looking at an ECG that's fast, you have to ask, why is it fast? And you ask, are there P waves? Or they're not P waves? Because this could be atrial fibrillation with a rapid ventricular response, for example. But you do see P waves here. They're fairly easy to see. They're at least here and here. So this is not probably atrial fibrillation. And you then always wonder when you have fast and you have a baseline that's wavy like this, whether or not if you took this distance, which maybe is about that distance, and you cut it in half, would you see something that is close to it? And I think the answer is you do. And so that's probably flutter. It could be a very fast PAT, and you can get into to word games about this. Flutter tends to be faster than PAT, but flutter can be slowed if there's a big atrium. We think some of the flutter is really reentrant, so if you have a big atrium, you can have slower flutter. But by and large, this looks to be flutter with 2-to-1 AV block.
Yeah. When it comes to trying to figure out, okay, what leads I'm looking to assess for something like an atrial flutter, a lot of people like to gravitate towards your inferior leads, leads 1, because a lot of times those give you great views of your P waves. I think in this scenario, leads 1, you can kind of, like if you really get to, by the time you get to V1, that's where you can clearly see it. It's really hard to see in your inferior leads in your lead 1, so it kind of just speaks to looking through all of your leads when you're assessing for some of these sneaky atrial fib, atrial flutters, atrial tachyes. Utilizing V1 and looking at that back end of your J point is always kind of like a common recommendation that I make.
Yeah.
And then also V2.
Well, the other hint is that you have a PR interval that's pretty short.
Absolutely.
And yes, we can have WPW or something of that sort that gives you pre-excitation and gives you a short PR interval. But you don't see anything to suggest that on this electrocardiogram. So it ought to say, with a heart rate this fast, you ought to have a longer refractory period of your AV node, and the PR interval shouldn't be quite so short. So it should make you suspicious to look more extensively at the rest of the tracing to make sure that you don't have a second hidden P wave.
Yeah, and also being suspicious, like with this being a resting exam, anytime you have a heart rate above, and kind of like just in the 120s, 140s, look to rule out any type of ectopic rhythm such as AFib, aflutter, atrial tachy, with it being a resting exam. So
now, one of the things that's very common, and it's poorly understood, and it's actually an area that's of some interest. There are STT wave changes here too. And if indeed this wasn't atrial flutter, we'd suspect, because in this instance they're more localized to the inferior lateral leads, that maybe there is ischemia present. And when you have an ectopic rhythm like this, there's some controversy about that.
Right.
But if QRS conduction is normal, then you still might not want to see that sort of ST depression, T-wave inversion. And these are the sorts of people who often, when they come to the emergency room, might have what we call a type 2 event or myocardial injury, that is to say, supply-demand imbalance, and some element of ischemia. And you can't call that all the time,
Right.
and more often than not, it's diffuse, but if it's not diffuse and it's focal, it's at least a consideration.
Otherwise, in terms of like the treatment of this patient, say we were to try to read this ECG, we maybe didn't see the extra P wave hiding in the ST segment in that J point. If we were to read this as sinus tachycardia, what would that mean for the patient and their care?
Well, again, it depends on the clinical context.
Right.
If you've got a patient who comes in because they've just had a psychedelic drug,
Right.
or even worse, something non-psychedelic that is harmful to them, or they're terribly ill and critically ill, maybe sinus tachycardia is a more reasonable diagnosis. On the other hand, if the substrate is different and the situation is such that there isn't a ready explanation, even if you've misread it as sinus tachycardia, looking again and saying, oh, could this be a primary cardiac problem like a rhythm disturbance, is always wise.
Right. All right. So since we kind of determined that this was atrial flutter with 2-to-1 conduction, if this patient was in the ER and maybe they were symptomatic, kind of lightheaded, dizzy, kind of all the above, how would they usually treat this type
Well,
of a patient?
first of all, one of the things that if you're suspicious you can do is to get an ECG that's double speed. So you can start
speed
to
and everything
see the P waves, and sometimes you can bring them out of the noise. There are all kinds of fun we can have. You know, you can do carotid massage, and these people will slow down. You can give drugs to slow them down. But if the patient is unstable, even with this rhythm,
Yep.
we would cardiovert such a patient if they were unstable. They're not. Then the question is, what underlies their proclivity to have atrial flutter, and do we need to address that problem as well as the primary rhythm disturbance?
Right. And then when you say cardiovert the patient, now obviously for some people may know that there's a difference between defibrillation and cardioversion. When you say cardiovert the patient, what do you mean?
Well, what you do is you put on leads, you detect the T wave, because if you put an electrical impulse on top of the T wave, you can induce abnormal rhythms, and you lose points for that.
Right.
So you try and detect the T wave and QRS complex. You then can synchronize the delivery of energy to avoid vulnerable spots, and the shock then is much more apt to be effective in reducing the arrhythmia if you need to use a shock.
Compared to like a defibrillation.
A defibrillation, you just take what you get.
Right.
And in that circumstance, where you're dealing with those sorts of abnormal rhythms, I'm not sure there are data that suggests that synchronization would help you in any way.
Okay. Anything else to expand on this,
No, I
this
think it's
example?
good.
Perfect. All right, our third example, a little bit different. We're slowing things down a little bit. When we analyze this ECG, the heart rate is definitely much slower. The computer throws out an asterisk, which is kind of like a red flag. That's how computer's not either recognizing too many P waves or an inconsistent PR measurement. But otherwise, the rest of our numbers look fairly normal. Besides, our axis is a little leftward, and when we're analyzing this ECG,
And it's a good example. I'm glad you pointed that out, because before we go to the rhythm, you've got normal initial forces, you've got leftward axis, then an increased R, and the R and R comes after the R and L. So this is a vector loop that looks like this. And that's an anterior fascicular block. Okay?
Okay.
But doesn't make the magic axis of minus 40, 45. We wouldn't call it. And I agree with that, by the way, because you don't have enough information for many of these patients to do that reproducibly. But it's just an example of what we were talking about.
So this might be a good example of, we do have for the technicians, for example, we have that typical left axis deviation would be that number off the top of my head, -30 to -44, and then -45 to -90. A lot of times we tend to stick really tight to these numbers.
Well, we should, because we
Yeah.
don't have the clinical information. But if you had the clinical information and it were to be appropriate, you might well say that this is an anterior fascicular block, just didn't happen to meet access criteria.
Right. So where technicians are maybe seeing some of you guys modifying some of their interpretations just based on some of the numbers and your guys' expertise, they shouldn't be surprised if they see you maybe update it to a left anterior fascicular block.
I usually adhere to the minus 45 criteria. I think and I think most of my colleagues agree, by and large, although we all have different styles,
Right.
and we all have different biases, that certain things we need to adhere to. That's one. The criteria, which I don't love, for LVH that are used in the immune system, I don't love.
Right.
But I adhere to them. And I think that if we don't, and we each one do our own thing, we end up causing confusion.
Yeah, lead to too many variables
Yeah.
when you're trying to analyze ECGs, absolutely.
Now, in this one, though, the PR interval does vary, and the question is, does it vary in some systematic way? So that when you're looking at differences in the PR interval, the way to think about it is it consistent or is it inconsistent? This is inconsistent. Is it inconsistent in some sort of reproducible way? And it does look like it is shorter, longer, drop, and shorter, drops, or it drops. Then here's another where it is shorter, longer, and then drops. So when you have classic AV Winkie-Bach, that's what you see. You see lengthening of the PR interval, and importantly, you see shortening of the RR interval.
Okay.
Because the increment of change gets less and less. And when you see this pattern, this is Mobitz 1, second degree AV block,
So your PRI lengthens,
right?
but your R to R
Shortens.
shortens.
Now, and when you then see it at 2 to 1, right?
Now, when we say 2 to 1,
That's a
two
block.
P waves.
Yeah, here, that one, there's just one other P wave, right? In the second group of complexes here. So you might not know if this is
Right.
Mobitz 1 or Mobitz 2.
Right.
You know, it's very likely Mobitz 1 for two reasons. One reason is that you've just seen a good example of Mobitz 1, and they tend to track together. If it's Mobitz 1 in one area, when it's 2 to 1, it's likely still Mobitz 1. But the second thing is that the QRS tends to be narrow,
Okay.
and that means you're still up in the AV node area,
Right.
as opposed to below the AV node. And you can get fooled on occasion with a rhythm that comes from the hiss, but by and large, when you see Mobitz 2, there tends to be a wide QRS
Okay.
complex as well.
So as for what you just described, so when it's usually a Winkie-Bach type of a rhythm, it's usually coming from somewhere around the AV node, correct?
Yes.
So it's more facilitated by the AV node, whereas Mobitz 2, you're kind of talking about his bundle, and it
Or
can
below,
or below and cause a wider complex.
Well, the AV node will give you a slower rate but a narrow QRS escape rhythm,
Right.
whereas things below the AV node
Right.
and maybe a little below the His as well tend to give you a wider QRS. And so you can use that as one way to help distinguish.
Absolutely.
Not that anything is perfect.
So when looking at this overall pattern, so you have that typical Winky-Bach pattern here, you go into kind of that 2-to-1 pattern here, and then back into that Winky-Bach pattern. Would you consider this pretty much all of this to be Winky-Bach?
Yes.
We just happen to go into kind of a 2-to-1 pattern.
Correct.
Depending upon where you might, especially as a technician, where you get your information, and even some textbooks, they'll look at this as you should classify this as Mobitz 2. But what's kind of just this concept in general of how Winky-Bach can progress to 2-to-1, this doesn't necessarily mean it's progressing into Mobitz 2, correct?
No. If it's got a wide QRS, it's more likely to, but even then, a junctional rhythms with a right bundle is possible. A junctional rhythm even with a left bundle is possible. So you have to be careful.
Right.
But the QRS width helps you.
Absolutely. So then as we're analyzing, whether you're talking like Holters, MCT events, inpatient telemetry, when you kind of have that baseline Winky-Bach pattern and it progresses into 2-to-1, we shouldn't be presenting this or classifying this as Mobitz 2 in our reports or to the nursing teams or the providers. This is just ultimately baseline Winky-Bach with kind of like a 2-to-1
No, but
pattern.
if the QRS starts getting wider, you better watch that patient more carefully.
Absolutely. And when it comes to like classifying Mobitz 2 on a 12-lead ECG, one of the things that I've been told is you want to be careful when classifying true Mobitz 2 on an ECG because that might force the clinician's hand to induce cardiac pacing. That's just something that...
Yeah, I think you've got to read them the way they lie,
Yeah.
and not worry about what it is. And if you think you're right, you've got to stand by your guns.
Absolutely.
Or at least that's what I try to do.
Absolutely. All right. Next one, kind of a different...
Totally normal, right?
Yeah, totally. Very normal. Your patient would be feeling just fine. Walk us through this ECG.
Well, there are more P's than QRS's, so there's some sort of heart block, and you've got a regular rhythm, regular QRS rhythm, it appears. So this looks like this is a junctional rhythm as an escape for complete heart block. You also have, although your QRS is narrow, you have ST elevation. First of all, you have a Q wave in 3 and F, and F really is the master lead. You can't have an inferior infarct without having a Q and F, because the other two leads, 2 and 3, go at angles. So you can have Q waves in those leads without having an infarction.
Yeah, that's so like, and you're talking about the way that we're looking at the heart kind of creates this triangle where you have lead 2, lead 3, AVF, and so AVF is that lead because it kind of is just right in the middle between the two.
Well, it's the only thing, it's all inferior.
Right.
So if another way to draw it is like that.
Okay.
So you've got to have a Q wave in F to have an inferior infarction, I would argue. And you have ST elevation in the inferior leads and in the lateral leads. Okay? So that is the right coronary distribution, so this looks like an inferolateral myocardial infarction. Now you also have ST depression in the V leads, in V2 and V3, and in 1 and L, which look at the lateral and posterior aspects of the heart. One of the ways in which some people have taught this in the past is that if you turn this ECG upside down and ran a light through it, you'd see ST elevation in V1 through V3 if you did it backwards. So this is possibly, although it could be aneuryseptal ischemia, possibly posterior myocardial injury, posterior lateral myocardial injury given that. So this is a person in whom you would want to make sure you had right-sided leads looking for RV involvement,
Right.
and posterior leads to document the fact that, as opposed to having to turn the ECG over and putting a light through it, you can document the ST elevation that is posterior.
Absolutely. So if a physician sees this ECG down on the ED, obviously they're worried, but if they see ST elevation in your inferior leads, your lateral leads, possibly posterior involvement, it's usually recommended to get that right-sided ECG and a posterior ECG.
Absolutely, while you're calling the cath lab.
Absolutely, because when it comes to like a right-sided ECG, you're keeping your limb leads the same, but your V leads are ultimately being flipped onto the right side of the heart, and then with a posterior ECG, before 5 and 6 become 7, 8, and 9, and then that's where you're just looking for evidence of continued ST elevation.
That's right, and for the right-sided, when you're doing right-sided leads, if you have ST elevation in those, you have during the first 24 hours, because the sensitivity and specificity of these criteria wane after 24 hours, you have evidence probably of right ventricular involvement.
Okay. When it comes to, this is a junctional rhythm with, you could consider complete heart block, correct? Mm-hmm. Because of the ratio between the P waves and the QRS complexes. When it comes to inferior MIs, is it common to have heart blocks in the presence of a...
Yes, and it's common to have vagatonia and with it hypotension. And if this person were hypotensive with this rhythm, you'd give them atropine to try and speed this rhythm up. But it's fairly common, and it usually bespeaks of a larger inferior infarct and sometimes a more proximal right coronary occlusion.
Absolutely. Because when you have that RCA, it's kind of wrapping around this way, correct? And you have those marginal branches, which ultimately kind of affects that AV node area. Mm-hmm. Which is exactly where your 2, 3, and AVF are looking.
Yep.
All right. And then kind of the other, with some of your clinical expertise on biomarkers and some of the research and articles that you've done, what would you expect to see from a biomarker standpoint? Well, first off, what are the common biomarkers that you would be looking to assess for cardiac injury, and what would the typical presentation
When
look
you
like?
have ST elevation like this, we don't wait for biomarkers at all.
Okay.
We send people right to the cath lab because the likelihood of this being an acute coronary occlusion or so-called type 1 event with plaque rupture and the like is very, very high. There's an occasional patient. You can be fooled. This could be Takotsubo's cardiomyopathy, but pretty unusual. And there are other reasons. There are other mimickers. But you would expect that this person would have an elevated troponin, depending upon the size of the infarction. And when you have this much ST elevation, and in particularly when you have posterior and lateral involvement, it bespeaks of a larger infarct size. You might well have elevations of other biomarkers like NT-proBNP, et cetera.
Okay. And then once they get to the cath lab and they correct the occlusion, how long do those biomarkers usually stay elevated for?
Well, the troponin can stay elevated for 2 to 3 weeks.
Okay.
Because there is a early releasable pool, and then there is a pool that's bound to the contractile apparatus, and that takes weeks to really degrade and be totally released. So you may not see that until such time as over time it wanes and goes away.
Absolutely. And in terms of some of the research that you've done on the difference between like type 1, some people may not even know that there's a difference between type 1 and type 2 MIs as they're kind of learning just how to read ECGs. When it comes to the difference between type 1 and a type 2, what's the fundamental difference?
Well, most type 1s are all atherosclerotic plaque rupture or erosion events with thrombosis on top of them. That's what gives you this picture. Now, you can get this picture with other things that are primarily involved in the coronary that get subsumed, at least given the present definitions as type 2, which include vasospasm, embolus, dissection, and both systemic dissection, because it can infect the right coronary artery in particular, and SCAD, spontaneous coronary dissection in women predominantly. So you can get ST elevation like this. Most of the type 2s, though, are not that. Most of the type 2s are issues where you have an increased demand, like tachycardia, hypertension. When you have that, you also have an abnormality in supply, most likely, because if your heart rate's going faster, diastolic filling time is shortened, and you have less coronary perfusion, so you have supply-demand imbalance.
Right.
And you can have ischemia for that reason, even though it's not atherosclerotic.
Right. So with it, is it fairly common to see your typical ST elevation like this with a type 2?
No.
No?
No. It's the only times you see it usually are with the type 2s where there's a primary coronary abnormality, such as dissection, SCAD, embolus, vasospasm.
Okay. And if they don't see, like with the type 2s that you would maybe not see ST elevation, would it usually present with some type of ST depression?
Usually it has this. If you take a look, T-wave inversion is associated with less myocardial damage than is ST segment change. And the magnitude of ST segment change has a reasonable correlation with the extent of myocardial injury.
Absolutely. And all right, our last one. This one's, we kind of definitely sped things up a little bit with this one. So when you analyze this ECG, your heart rate is definitely much quicker. Not incredibly fast, but it's definitely fast for a resting ECG. Your QRS is wide. QTC, you can't really, when the heart rate's above 100, it's not really a reliable measurement.
It's not accurate, that's right.
And then our access, however...
And even when you have a widened QRS, there are arguments about how one should correct the QT interval.
Okay.
And some people would argue that you make the QRS 80 milliseconds and sort of subtract the size of the additional conduction of the QRS to calculate the QT interval. Some people don't believe that at all. So there is some degree of ambiguity about how to do it when you have a conduction defect like this. So you wouldn't look at that.
Absolutely.
What you would look for is whether or not, as in the first situation with tachycardia, whether or not you can see P waves. You can start guessing and say, could that be something? Could that be something? Could that be something? Could they be retrograde? All right, really hard to tell. If indeed they are consistent, the more consistent they are, the more apt you might be to consider a supraventricular arrhythmia. The more inconsistent they are, you might think more about a ventricular tachycardia. In addition, you need to be careful because some ventricular tachycardias can go retrograde and still activate the atrium and give you a P wave anyway.
When you're talking retrograde conduction, can you describe what you mean?
Sure. Let's just say that the arrhythmia started here, goes back up, and can activate the atrium.
Perfect.
Now, when you see this, however, this is a very wide, complex, atypical QRS. It's not what you normally would expect from supraventricular tachycardia with aberrancy, which tends to be right bundle,
Right.
or even a typical left bundle. There are characteristics of this because of its width, because of its concordance across the precordium, particularly over there in V5. It's not all that formally left axis evades, but it's got an indeterminate axis. This is very likely ventricular tachycardia, all things being equal. And quite frankly, if you're not sure and the patient is in trouble, we almost always would say to our house officers, if you're not sure, treat it.
Yeah, absolutely. Kind of like when I initially look at the ECG, I just see that initial R wave deflection here in AVR. That sometimes tends to be just like an indicator, just that initial R wave in AVR. You mentioned the width of the QRS. And kind of another one of the things that I've been taught, whether it's different presentations from fellow physicians or just looking at other ways to analyze wide complex tachy, when you have the presence of a 12 lead and all of your leads are going kind of in the same direction, having that concordance,
Yep.
That's usually another really, really good indicator for ventricular.
Well, the other thing is,
tachycardia.
and it's one of the reasons why looking for P waves can be helpful, which is if they have an association with the QRS, it's less likely to be VT. Usually with VT, they don't have an association with the
Right.
QRS.
Looking, so like I know one of the top things that would maybe designate more of a VT would be having that AV dissociation.
Yes, exactly.
With what you're talking about, yeah. From the technician standpoint, if they're not really able to determine like VT, SVT, because there are times where somebody might try to read it one way or the other. If they were not 100% sure, interpreting this as wide complex tachycardia and letting the provider taking care of the patient is something that we've been recommended to do. Is that something that...
Yeah, that's perfectly reasonable. If you don't know the right answer, trying to guess is not a good idea.
Absolutely. So then it would be one of those things where you would maybe say wide complex tachycardia and letting the providers ultimately make that
Yes.
decision. Okay. So Dr. Jaffe, I just want to thank you so very much for joining us for our first installment of ECG Insights. That's the end of this presentation, and I thank you for your time, and I look forward to hopefully having you on again.
My pleasure.